Okay, so good morning, good afternoon, and good evening, everyone. And I'm so happy to see all of you again. And we have so many familiar faces. And it's the Chinese Lunar New Year now. And it's a festival that gather the family members together. And I think this time we are getting ACNS families members together in this special occasion. So our chair today is Professor 𝑦𝒑𝒂𝒃𝒊𝒂𝒓, and who is the assistant professor of the Department of Neurosurgery in Brain and Cerebrovascular Center, King Touchin Memorial Hospital in Bangkok, in Thailand. And today we have three speakers. The first speaker is Professor 𝒂𝒃𝒊𝒂𝒓, who will be talking about the endovascular treatment for blood blister aneurysms. Our next speaker is YNS speakers, Dr. Harry King, and who is talking about a review of recent endovascular treatment of cerebral aneurysm. Our third speaker is Professor Sharon, who will be talking about the MVD for trigeminal neuralgia. Our discussant today is Professor Olisang and also Professor Pritchard. And to moderate the sections with me, we have Sachin with me, and also I have a special guest who is next to me is Professor Takashi Kon, who kindly visit Hong Kong today. So shall I invite our chair, Professor E.T.? Can you please introduce our speakers?
Yes, thank you, everyone. It's a good afternoon from Thailand. Thank you for Professor Kokato again and YNS webinar, Dr. Sachin, Dr. Ben to invite me to be a chairperson for this webinar. So the first speaker I can introduce Professor 𝒂𝒃𝒊𝒂𝒓. He's a chief doctor in neurosurgery. Now he I'm from the first affiliate hospital of 𝒀𝑵𝒊 University, 𝒀𝑵𝒊 in China. Today he will talk about the very interesting topics for endovascular treatment for blood blister aneurysm. This topic, I think, we have a benefit from the topic because this blood blister like aneurysm is really difficult to treatment. So today, Dr. Xu will give about the about the core principle of treatment. Please welcome Professor Xu to talk about this topic.
Okay, I could talk about the So at the very beginning, I would like to take this opportunity to thank especially Professor Kokato, because actually I was a student of Kokato. Because 20 years before I was follow Professor Kokato and Professor Kano and Professor Sano. And that's very sweet memory for me. Can you see my screen? I'm not sure you can see.
Yes.
Go into the presentation mode.
Full screen or just okay? Now it's done. Okay.
Yeah. Good.
So today I'd like to talking about the endovascular treatment for the blood blister like aneurysm. At the very beginning, I'd like to introduce myself. I come from China, from Suzhou City, and which is very close to Shanghai, only 27 minutes away from Shanghai. And I was usually open surgery, open neurosurgeon. That means I also doing clipping surgery. But from the 2013, I study also study for the endovascular treatment for the intracranial aneurysm. So today I'd like to share some experience about our experience about the endovascular treatment for the blood blister like aneurysm. So actually, from the very beginning, I still remember 20 years before, when I first in front of the blood blister-like aneurysm, because at that time we don't know what is exactly this aneurysm is. We don't know the BBA. We just have a case during the operation. We found a very tiny, very small aneurysm located anterior wall of the internal cardiac artery. I mean the opposite side of the posterior communicating artery and anterior choroidal artery. So very small and very tiny, and we just and also you can see the aneurysm very tiny but transparent. You can even see the blood flow inside of the aneurysm. We just put a small clip on the neck of the aneurysm, but it start to bleeding, and you can see the clip just fall down, and you just see a hole on the anterior wall of the internal cardiac artery, and you just lose your operation view. We are all in panic, and we just put the cotton and put the hemostasis material on the hole and try to stop the bleeding. And during the operation, we also use a glue to prevent the bleeding. Finally, we stopped the bleeding and just use a glue and the cotton. And then we go back to the ward. The patient still good, but 1 week later, the patient ruptured again, and we lost that patient. So impressive, that case. So still I remember that day. But finally, after many years, we realized this is a blood blister-like aneurysm. So the concept of the blood blister-like aneurysm is usually you can see a very fragile aneurysm wall, and it's very high rupture rate during the operation. And it's where this kind of aneurysm have very high risk of the regrowing and the rebleeding rate. And that's why this kind of aneurysm is very challenge for the neurosurgeon and have very high mortality. So this is some background knowledge about the aneurysm. Actually, it's very rare. And maybe some doctors, they never see this kind of aneurysm, and also some doctors saw this aneurysm, but they didn't realize this kind of aneurysm is BBA. So only 1% of the internal carotid artery aneurysm. And from the histopathological examination review that this kind of aneurysm, they don't have the real aneurysm wall and solely covered by the outer membrane and the fibrous tissue and without collagen tissue. And also artery sclerosis also involved to the local aneurysm. So this is very different from the usually we know the sacral aneurysm, and also different from the dissecting aneurysm. So, and also from the angiographic examination, you can see most part of the aneurysm BBA is located at the supraclinoid internal cardiac artery. And usually you will see this kind of aneurysm is projecting anteriorly, and you will see which located at the non-branching sites. Although the aneurysm is very small size, but with a very broad basal appearance and or irregular protrusions. And now we're talking about BBA. One important concept is we're only talking about the ruptured one. Of course, there's still controversial. If some anterior wall internal cardiac artery is kind of BBA or not, but now we're only talking about a ruptured one. So usually from the CT scan, you can see the subarachnoid hemorrhage from CT scan usually will corresponding to the aneurysm site. And if you have chance to repeat the angiographic examination for the patient, if the patient refuses to treatment to treat the aneurysm, you have to ask the patient to repeat the angiographic examination. If you got chance, you can see the very rapid growth, and even after treatment, you still can see the different shape and the aneurysm regrowing and bleeding. And also this also can help you to confirm that this kind of aneurysm is not a usual aneurysm. This is kind of a blood blister-like aneurysm. So this is our criteria to diagnosis blood blister-like aneurysm. First, if you see an aneurysm which located at the supraclinoid internal carotid artery, and especially this artery is at the projecting to the anterior, and it's located at the non-branching site, and also the hemorrhage corresponding the aneurysm site, and especially when the aneurysm is very small, and even you can miss diagnosis it. So this is a suspected BBA. And if the patient recurrent bleeding and then you have to highly suspect this is a BBA, especially you have the evidence from the angiographic examinations that the aneurysm shape and size is changing, rapid growth or early recurrent. Then you have to confirm this is a BBA. So now we have a very main strategy to treat this kind of aneurysm. Of course, at the very beginning, even now, still doctors, they have the two strategy to treat the blood blister-like aneurysm. Of course, we have to always remember microsurgery can treat the aneurysm. We can do in the clipping and wrapping to treat this kind of aneurysm. You can use cotton, and you can use some membrane, and even the artificial dura mater to wrapping and clipping the aneurysm for some of the case. And if you have the technique, the macro suturing, you can suturing the ruptured point. Of course, this is very high technique and very emergency. And if you cannot stop the bleeding, another way is trapping the aneurysm, which means aneurysm occlusion with or without previous protective bypass. So, but usually we, in our standing, it's always an emergency case. Sometimes they just face the BBA during the operation. They all got into panic, so they have no chance to do the protective bypass. But now, if they realize this kind of aneurysm is blood blister-like aneurysm, usually they will recommend to us doing the endovascular treatment. So we can do in the coring, we can do in the stent-assisted coring, and also we can do the coring combined with flow divert devices. So let's talking about how to treat this kind of aneurysm. Is a simple coring is doing the job. So from the published articles, they found that actually is if you follow up or if you only simple coring the aneurysm, usually it will associate with a very high risk of the intraoperative ruptured and regrowthing. So, but only the endovascular IC trapping maybe can achieve the good recovery. So only the simple coring usually is not the right treatment for the BBA. And also, we talking about the single stent assisted coring embolization. So usually we use semi-gelling and gelling technique to, we also call this is a kind of riveting embolization. So you have to not only embolize the inside part of the aneurysm, you also deliver some the coils a little bit outside of the aneurysm. I mean some part of the aneurysm wall to do a riveting embolization. So this is a case, actually, this is not a successful case. This is a very bad memory for me. This is a very young patient, only 45 years old, and got a subarachnoid hemorrhage. And this is CT scan. You can see the swollen brain. And at the very beginning, you can see a very not so obviously protrusion from the left side internal carotid artery, the distal part of the left carotid artery. See the angiography examination, you can see very small protrusion here, and even you can see a very small aneurysm located at the very beginning, original from the anterior cerebral artery. So we didn't act. This is a three-dimensional. Yes, this is three-dimensional rotation of the image. So you can see the very odd and very weird shaped aneurysm. So we just at that time we just make the in position of the standard cassette, and we prepared to use Elvis stent. Then we make position of the super selected aneurysm, use Antron 10. We just give the coils, and we make a dense embolization. And we didn't embolize the small aneurysm located at the beginning of the anterior cerebral artery. And from this image, you can see it's quite dense in embolization for the aneurysm, and also we also deliver the Elvis stent well. The stent open very well, and this is final image. But after the operation, we found the patient not wake up, and no obviously spontaneous breathing. We think some problem maybe happen, and bilateral pupil are equal large, but then without any light response. And meanwhile, although the blood pressure is stable, but the dynasty scan indicates some new bleeding. So that's after the patient come back to the ward, we take the patient repeated CT scan with endotracheal intubation. So we found the aneurysm definitely ruptured again. And we go back to the image during the operation. We found at the aneurysm already ruptured during the operation, and you can see there's a small protrusion here. And that's one we didn't detect at the very first angiographic examination. So this is just change the shape immediately during the operation. So this is a BBA of the left internal carotid artery distal segment, and the morphology of the aneurysm changed immediately after embolization. And then the patient's blood pressure just soared to the very high 180 over 120, and dilated pupils. And this patient is left the hospital without a cure. So this is a very terrible memory for us. So, and also we find the article that a single stent is very difficult to cure blood blister like aneurysm, because only single stent its metal coverage is very limited. So after that, we think we have to do the parent artery reconstruction, not only to embolize the aneurysm. So we think about the overlapping Elvis stent and plus a coil to treat this kind of aneurysm. This is another young patient, 36 years old, and got hypertension and got a ruptured aneurysm. At the very beginning, you can see a very small, very tiny, but very wide and very broad neck of the aneurysm, left side. This is the angiography examination. This is three-dimensional angiography. You can see the small, tiny aneurysm located in the anterior wall, and you can see another small protrusion here, and also very wide, broad neck. So we just make sure the position of the first stent cassette, and here is micro cassette of the corium, deliver corium. So we make positions the corium cassette, and we deliver the first stent. We just semi-delivering the first stent. Then we start to deliver the coils. from inside to outside, and some part of the coils is attached to the wall of the aneurysm, and also the internal carotid artery, and we just leave a double Elvis here, and this is three-dimensional reconstruction. You can see the relationship between coils and the stent. Yeah, this is a relationship between coils and the stent. It's the final image, and also we repeated. Usually before the patient discharge, we will repeat angiographic examination, and this is 1 month later follow-up, and the aneurysm is totally occluded, and this 3 months is follow-up. And after that, we ask the patient to come back to hospital, but patient refused to come back to take the angiographic examination. This is another 57 years old male patient, got a sudden headache, and got ruptured right side ICA-BBA. This is the image of the CT scan, and you can see very wide neck aneurysm located anterior wall of the right side internal carotid artery. It is a angiographic examination, and we just also deliver 2 double Elvis stent and the core is the aneurysm. So you can see the double stent here, and this is a embolization of the coils. This is a final image at after the treatment. This is three-dimensional reconstruction, and patient recover well. And this is another 56 years old BBA patients. This is CT scan. At the very beginning, we just misdiagnosis aneurysm because we from this image you cannot see the aneurysm. But from the so this is very typical story about the BBA. At the very beginning, and CT angiography examination, you think this is maybe the negative finding, but from the digital subtract angiography examination, you found there's aneurysm here, very clear. So we just not only coiled the aneurysm, we also delivered 2 Elvis stent. This is after the embolization. You can see the also we just Elvis stent is local compressed. Also, we think this can act like something like a blood flow divert effects. This is final image of the treatment, and the 1 month follow-up, 3 months follow-up, 10 months follow-up, and 26 months follow-up. The patient insists to take the follow-up examination, but after the 26 months follow-up, we think it's safe. So there's also some published articles that overlapping stents also can play some hemodynamics like flow divert effects. So our colleagues from Shanghai, they also published this article that the overlapping stent provide less risk of the BBA recurrence compared to the non-Elvis stent. So it's a very good choice to use double Elvis plus coil to treat the BBA. But we also use not only use the Elvis, we also use overlapping enterprises stent to treat this aneurysm, because in a period we don't have the Elvis available in our hospital. We only have the enterprise stent in our hospital. But we encounter this kind of patient, very young patient, 46 years old, ruptured aneurysm, CT scan, and it's very typical BBA, small but with a broader neck on the right side internal carotid artery anterior wall. And we just embolized and you can see during the embolization, the size of the aneurysm is much larger than your imagination. So it's quite dangerous. So we use very small and softer coils and to analyze the aneurysm. And also we deliver the first enterprise stent here. Then we are going to go through the first stent to make sure and going to deliver the second enterprise. But can you notice here the stent is just displaced and just shifted towards the distal part of the middle cerebral artery, and it's quite dangerous if we keep push the stent cassette, then maybe the coils will come out, fall into the parent artery. So we just stop. We just think we cannot. It's difficult to put another enterprise stent. We just stop it. And 1 week later, we found still some residue neck over here. So 1 month later, the patient developed hydrocephalus, and consciousness is a little bit deteriorated. So we performed the VP shunt for this patient. And 1 month later, we also repeated angiographic examination. And so we decided to repeat again because we think now the first enterprise stent already very close adhering to the parent artery, so we can go through the first stent to treat the aneurysm again. This time we also doing some coring at the neck of residual neck of the aneurysm, and then we deliver the second enterprise stent. But still you can see some contrast agent still can be seen in the neck of the aneurysm. So this is three-dimensional construction, and this is 4 months later follow-up. You still can see the residual neck of the aneurysm. And 14 months later follow-up, we found the aneurysm is still growing, very terrified. And you can compare to the formal image, the aneurysm is still growing. And then we also think about the trapping internal carotid artery, but we're also doing the compressed angiography examination. But we don't think this is a good choice for the patient, because the patient so far everything is stable, no headache, no symptoms. And we think about use a flow divert device. So we just leave a flow diverse here, and a little bit influence of the anterior cerebral artery blood flow. But of course, we already performed the compressed angiography examination, so we think it's safe to cover the origin of the anterior cerebral artery. And the three-dimensional construction shows the flow divert is open well, very up position. But still, 6 months follow-up, we still can see some part of the residue of the neck of the aneurysm. And we just manage the anterior platelet agent, observe and follow up this patient. But so far, the patient, the symptom is stable and no further symptoms. So this also makes us think about the anti-platelet therapy on BBA hearing. This is another interesting case. This is a very terrible subarachnoid hemorrhage patient. And so you can see the aneurysm almost involve the whole parent artery. This three-dimensional DSA, and from this image, you can see the aneurysm actually almost involve the parent artery, and with a small protrusion. And we performed the double LV stent plus coils. We deliver the first coil inside of internal carotid artery, then we deliver first LV stent, just cover the whole internal carotid artery. But here, the small protrusion, we cannot let the coils reach this point. It's quite difficult. But at last, we think there's a conscious retention here. So we think it's safe. This is the final image, and the three-dimensional. So far, it's good. and the patient recover well during stay in the hospital. And then we perform follow-up 15 days, just 2 weeks after the first operation. We just found the aneurysm is closing, and especially the small protrusion is enlarged at this point. This is a 3-dimensional DSA. So it's terrible. It's terrifying us that it's closing. So, but problem is there's two overlapped Elvis centers there. So it's very difficult for us to like super selection the aneurysm through the previously double Elvis stent, what we can do. And we just prepare the anteron, and we just prepare the third Elvis stent. So we just we cannot super select the inside the aneurysm. We just like a sandwich. We just deliver some part of the aneurysm at located the aneurysm wall and deliver the third Elvis. But fortunately, it's also our lucky that you can see the retention inside of the aneurysm. So we stop the surgery, and 10 days after the surgery, the second treatment, we found that aneurysm is gone. We are so happy that the aneurysm was cured. So this is the working projection. You can see the aneurysm is gone. And also the parent artery blood flow is patterned. And the 1 month follow-up is good. So after the second treatment, so we just give the patient only aspirin and oral take, and 2 weeks follow-up show the aneurysm was totally occluded, and the parent artery was patterned. And this is we also perform the VP shunt for this patient 1 month after the second treatment. So now maybe more cases we perform now is use the flow divert device to treat it. And this is some published articles about the pipeline to treat the BBA. But this case, and this is very interesting because in these articles, they only treat 8 cases of BBA, but without any coring. They just deliver pipeline. But all 8 cases got totally occluded. It's quite interesting. And this is another article about the silk stent. They treat 11 cases BBA without, and then 9 of the case is without any coring. This is quite interesting. And this is the meta-analysis of the flow diverted treatment of BBA. This is about like 80 cases, and total occlusion rate is 72%. Recurrence rate is about 13%. Repeating rate is 3%, and the long-term good prognosis rate was 83%. It's quite good. And in long-term follow-up, there was no significant difference in cure rate between single pipeline and multiple flow diverted device. So this is our experience. This is a very young patient, 28 years old female. And this is from this image, you can see the anterior wall, very tiny but very broad neck aneurysm here. And you even can see the pumping of the aneurysm during the angiographic examination. So this is quite a dangerous aneurysm. Also involves part of the parent artery. So we first try to make the stent cassette go through the aneurysm and to the distal part of the middle cerebral artery. And difficult for this kind of case is position of the microcassette of the embolization. I mean the it's very difficult to place the macronucleic acid of the coring. So in this case, we just make a J-shaped antral, then make it in position, and we just deliver very slowly and very soft coils here. After deliver first coils, we just deliver the tuberage stent. This is our Chinese flow divert device, the very first one flow divert device in China. Okay, this is we are releasing the flow divert device here. Make sure it's open well and a position. Then we deliver the rest of the second. Of course, this is we always to go through the stent by to make sure the every part of the flow divert device is open well. And then we keep to coring the aneurysm. We skip this part. And this is the final image. Okay, this is a final image. This is a reconstruction after the operation. You can see the relationship of coil and the stent. Then this is a 3 weeks follow-up. Although there's a stenosis at the very beginning of the operation, but now it's resolved. And this 3 weeks will follow up, and this is 6 months follow-up. The patient recover well. This is 6 months follow-up. And we also doing some hemodynamic study in this series of aneurysm. So we just collect the image and send to the software to analyze the hemodynamic change of the aneurysm before and after we deliver the aneurysm. So you can see here. The software can mimicry the blood flow inside of the internal cardiac artery, and also can mimic the impact of the blood flow to the aneurysm. And this is also this material also can help you to diagnose the aneurysm if the height and the neck the ratio is 1.3. Also can help you to diagnose it, and also angle, the inflow angle and distal aneurysm angle also can help you to diagnose bladder blister-like aneurysm. So this is mimics the coring and the deliver of the flow divert, and also can calculate by the computer to calculate the velocity contour of the aneurysm. You can see before and after the surgery, you can see the difference, especially the velocity isosurface and the velocity streamline before and after the surgery. So it do help us to find that after deliver the flow divert, it do decrease the high flow volume impact to the aneurysm wall. This is another young patient, 30 years old female. When the patient got a sudden headache and CT scan shows a subarachnoid hemorrhage, but patient refused to treat. At this angiographic examination, we think this is already can diagnose blood blister-like aneurysm, because this is a tiny aneurysm with a subarachnoid hemorrhage and with a broad neck. We believe this is a BBA, but the patient refused. But we ask the patient to stay hospital, and 1 week late, we just repeat the angiographic examination. But now you can see the aneurysm close up, enlarged. Then we discuss with the family member, it's quite dangerous. We think we should fix this aneurysm. but we got a problem during the operation. We put the stent cassette in place, but when we try to placement of the microcassette into the aneurysm, it's very difficult, especially when you deliver the flow diver device. Your microcassette inside our aneurysm is not stable. It's always come out. So finally, we just leave some part of the coil inside the aneurysm because it's very, very, very small, and we just deliver the flow divert stent here. And we just finished the operation. And this is final image. You can see the stent open well or very well, and aneurysm is just disappear. This is three-dimensional reconstruction. You can see the aneurysm was gone. We also analyze the hemodynamic of the expansion. We also found that after we deliver the flow divert device, the impact to the aneurysm blood flow is decreased. That's why I also explain why the patient can benefit from the flow divert device. This is before and after surgery flow divert. This is 12 days follow-up. We still can see some contrast inside the aneurysm, and we just adjusting the antiplatelet medication, and 3 weeks later we repeat the CT angiography examination. We found the aneurysm was totally occluded. This is 3 weeks follow-up, and 2 months is follow-up. The aneurysm is gone. Plus about half years and 6 months is follow-up. We see the stenosis here. This is also one question I'd like to ask you, your professor, how to deal with this kind of stenosis after the flow divert device. So we think the parent artery construction is very important. So also we think about the covered stent. And they also, some articles they published to use covered stent to treat the BBA, but only one patient was died during the operation because of the ICA ruptured during the delivering the covered stent. But still, it's an option for the BBA. So this is another multiple center about the BBA treatment. This is 212 cases collected from 22 medical centers in China. They use a single stent. Half is use a single stent. Double stent is about 1/3, and only 15% is use more than 3 stents. See about the enterprise and heavy stent, not flow divert, but still the good prognosis is still satisfied. So I'd like to discuss that. Of course, when you face blood blister like aneurysm, you always think about clipping or interventional. Now in our department, most of cases are sent to me to use the endovascular treat the BBA. And also you have to notice that you have to choose a very right material. I mean the gateway, stent cassette shaping, during operation, and also you have to select the suitable stent. And also walking path also very important. Now we have very good intermediate cassette to give us very good support, so we can make sure the flow divert device can in position. And for coil selection, we recommend that you use as much as possible to use the small and soft coils, just to prevent the perforation of the aneurysm during the delivery of the coring. And we recommend the use, if you don't have the flow divert device in hand, we recommend to use multiple stents, not a single stent. And we use a flow divert to plus coil to riveting technique to treat the BBA in our department. And no matter what kind of treatment you do to the patient, early repeated follow-up is very important. The conclusion is BBA is a very special kind of ruptured aneurysm. You should pay very carefully attention and just prevent it from the misdiagnosis, because it's really happened even in our hospital, because it's very tiny, small, and maybe you can misdiagnose it. And also aneurysm isolation also is a still reliable method to prevent ruptured and rebleeding, but still got some complication like a stenosis, ischemia, infarction. If without a bypass, or even you have the protective bypass, you still will in phase to the ischemia. And stent-based endovascular reconstruction is a feasible method or strategy for treating the BBA. So use of the stent semi-release technique combined with the gelling technique also help us to achieve dense embolization of the aneurysm, and also can improve the technically success rate. So overlapping stent technique can improve the treatment effect, and also can act some flow divert-like effects. Blood flow devices are the trend, and now is the direction in treatment of this kind of aneurysm. And regardless of the vascularization technique you used, repeated short-term follow-up always have to keep in mind. It's quite important. But we still have some problem we cannot resolve. And also we can say some controversy here. And how about the follow-up duration for the patient? Lifelong time follow-up, when we can stop the follow-up, and how and when to retreat the recurrent BBA aneurysm, especially when the patient symptom is stable, like one case in my series. And how to management of instant stenosis and interval hyperplasia. That's also a headache for us. And also how to adjusting and how to management of the oral take antiplatelet agent. And when the aneurysm macrocassette cannot in position, you keep to doing the position of the macrocassette, or just simply deliver one flow diverter device. That's the question I want to ask from you. I want to hear from your advices. So thank you very much.
Thank you so much, Professor Zhu. And maybe shall we invite comments from our discussion? Professor Ellison, any comments?
Yes, I have. Thank you. Thank you, Ben. Thank you, Professor Zhu. First of all, my congratulations. You presented an excellent cases, very difficult, and it treated very successfully, like a state of art. Thank you. Thank you, and congratulations. I think I have a couple of minutes to tell one short story of my first experience with the blister blister-like aneurysm. At that time, I visited Professor Ernest Niemi in Helsinki. He operated.
Also, he's my teacher also.
Also, you see, and I
Yeah,
assisted him at night. He clipped the MCA aneurysm, and then he revealed a very small blister on the ICA. What he did, he just coagulated it, shrunk, and that's okay, that's fine, that's enough. I don't know the destiny of this patient in the future, because I don't know the story, but it was I was a little bit stressed with this, because it seemed to me very dangerous to coagulate the wall. He was absolutely confident in himself, just shrunk, and that's okay, everything will be fine. So okay, now Professor Zhu, you highlighted the controversies of this management. Of course, of course, the endovascular method gets more and more effective and more safe. It's year by year it gets more and more obvious for everyone. The only problem of endovascular method, it's the highest rate of complications is from the thromboembolic complications. That is why the antiplatelet therapy gets very important. You showed the case,
Yes.
but you didn't develop this problem, and I ask you to discuss a little bit about it, because from the one side, you know, the occlusion of the aneurysm after endovascular, the rate of occlusion is not so high, about 30, maybe maximum 50% and that all. But in couple of months, we have up to 80 and even more percent of occlusion. But this period, the patient must be protected from one side, protected by antiplatelet, but also we are waiting for occlusion. So how can you comment this controversy? So please develop this idea. I'd like you to comment it.
Actually, this is a very good question, and a very professional question for me. And I also had followed Professor Hnezmir in his department in 2008. And you mentioned Professor Hnezmir clipped, I think that's an unruptured anterior wall small aneurysm, not ruptured. Yeah, that's why I know he'd like to adjust the very small volume, the coagulate rate, and then maybe 4, maybe 8 coagulate and make it shrink. Yes. And but your question is very good, because it's kind of dilemma. It's a very headache dilemma for us to, of course, after the deliver stent, you have to give the patient antiplatelet medication, but also you're afraid of the bleeding or reclosing of the aneurysm. But of course, that's why we also put some coils inside our aneurysm, not like our other colleague from other countries. They just only deliver one divert stent. They do not doing any coring, but they also give the patient antiplatelet medication. So our opinion is we not only to deliver the flow divert, we also make sure that the as much as possible you have to try your best to embolize the ruptured aneurysm. Make as much as possible coils inside our aneurysm. That's one key point to prevent it rupture. Then you feel safe. You feel very safe to give the patient oral take antiplatelet medication, and we just give the patient the regular dosage of the antiplatelet medication after the surgery. That's our answer. But we still, of course, you still cannot make sure 100% that aneurysm can occlude. You still have to repeat it short-term angiographic examination. This is our opinion.
As you mentioned, yes. Thank you very much. I understand it's a tough problem, and your option is very interesting. Really, you decrease the pressure on the aneurysm wall by inserting on the coil. So you decrease the risk of rupture post-op, and patient has more time and more safe period for the occlusion of the aneurysm. That's really good idea. So thank you very much, and my congratulations again.
Thanks for the question. Thank you.
Thank you. And any comments from Professor Priesel?
Hello, thank you, Professor Zhu. Very excellent presentation, and congratulations for your achievement. Thank you very much. It was very excellent presentation. I'm Dr. Prizat from Afghanistan.
Okay, hello.
Thank you.
Any comments? Yeah.
Thank you.
Okay. Maybe Professor Kato, you have any comments to the difficult questions raised by Professor Zhu?
Okay, thank you very much for a nice presentation. So I think maybe so far my experience, I think he make some small coagulation of the anterior wall aneurysm, which is not a rupture case. I think that is not true. Blister-like aneurysm, I think. Maybe the pathology is different. So it looks like
Yes,
anterior wall aneurysm, but
Agreed.
it is not, yes, not total, the so-called blister-like aneurysm.
Yes.
So that is one. Another one is, I think, your final solution is maybe the multiple stent with sometimes just one or two coils. I think that is maybe, I think it's very ideal one. I think. But I don't know why, your question during your lecture, so maybe some stenosis after some times. Yes, I don't know what was the mechanism, why it became some stenotic, I think. Maybe some aesthetic change, or how to think about? Or do you have any solution for that case?
Yes, we also think about that. We believe that the internal hyperplasia inside of stent, because of the stent stimulate the wall of the parent artery. That's why they make the stenosis. One of our option is we can use a balloon. If the patient got the symptoms, we can use a balloon to enlarge the stenosis part to make the blood flow pattern again.
Mm-hmm. Okay, thank you. Congratulations. It was a really nice presentation. Thank you very much.
Thank you very much.
Thank you. So,
we have a raised hand from Dr. 𝑣𝒃𝒊𝒏𝒂𝒓. You have a question?
Yeah. Hi, Sensei Kato and everyone. I myself, Dr. Shahnawaz from Dhaka, Bangladesh. I have questions to Professor Wu. It was an excellent presentation. I used to being trained up under hybrid neurosurgeon, Professor Shafiqul Islam sir. So my question is, for the blister aneurysm, what are the points you consider to go for embolization with LVG stent or flow diverter, or just only flow diverter? What are the points you consider to choose this device for the coil embolization?
Okay, this is also a very good question. This is also, we always think about this question in our mind. Of course, what kind of stent we choose depends on in our hospital what kind of stent is available for us. Of course, from now, if everything is all good, I prefer to use flow diverted stent plus the coils to treat this aneurysm. If we don't have the flow diverted device, then we also can use multiple LVS stent. Like, of course, I prefer LVS stent more than the enterprise stent. And also, you also mentioned to doing the coring or not doing the coring. We also quarreled, and we also discussed with some doctors, because sometimes it's also quite dangerous to select the small tiny aneurysm during the operation, because it's so fragile wall of the aneurysm. It's also quite dangerous. So some doctors, they think if the aneurysm is so small, if it's less than 3 millimeters, they believe they can only deliver a flow diverter device and without any coring. If more than 3 millimeters, you have to doing some coring, because if the larger the aneurysm is, the much easier to perform coring. But if the smaller the aneurysm size, the more dangerous to perform the coring. That's my answer.
Yeah. One more supplementary questions, if I'm allowed to ask. Sir, the manipulation of the microcatheter within this blister aneurysm is very risky job. Do you have any tips for that?
Yeah, of course. You have to make sure it's very well shaped. We use a steam to shape the microcatheter end of the microcatheter, and try to approach into the aneurysm as carefully as possible. Don't push it. And sometimes we use the coils and the microcatheter together to put into the aneurysm wall. And in my experience, I think even some small part of the coils going to the aneurysm also can help to thrombosis of the aneurysm. Also can help to curing the aneurysm. That's my answer.
Okay, thank you, Professor.
You're welcome.
Is there any further comments on the floor?
Okay.
Yeah. Professor Takeshi?
I'm Dr. Kong from Tokyo, Japan. Thank you for the lecture. Nice presentation. As for endovascular surgery, so because blood prehistoric aneurysm BBA, so the wall is so sometimes fragile. So preoperative SPECT or preoperative blood circulation evaluation, how do you manage before surgery?
You mean how to choose clipping or to choose endovascular treatment?
Yes, before endovascular treatment. So the flow will change after even if endovascular surgery. So sometimes hypervascular, so sometimes overvascular or hyper perfusion. So the perfusion is also evaluated before surgery.
Yeah, we discuss with open neurosurgeon,
Okay.
but now in our department, because for the open neurosurgeon, I know their story. They experienced a very tough time during the open surgery. They put a clip, then it ruptured, and they lose the view of the operation, and the patient, most of the patient actually die. So now, if they realize this is a BBA, they always recommend the patient to me to select the endovascular treatment.
Okay. Thank you.
Okay, thank you so much. So maybe we shall move to the next YNS speakers. The next speaker is Dr. Harry Curran, who is the Associate Consultant of the Department of Neurosurgery and Spine Surgery in Calvary Hospitals in Bangalore. And his topic would be review of recent and vascular treatment of cerebral aneurysm. Dr. Harry, can you share your screen?
Hello. Can you see my screen?
Yes, please.
Am I audible?
Yes, please go ahead.
Yes. Thank you. Good evening, professors and colleagues. I thank Professor Kato for giving me this opportunity. And let me introduce myself. I am Dr. Hari. I'm currently working as Associate Consultant in Bangalore, India. So today's my topic is review of recent endovascular devices. So I'll briefly talk about the endovascular devices, and straight away, so I will move to intrasaccular flow disruptors, leaving out the regular coiling and flow diverters, which we commonly discuss. So I wanted to discuss the recent topic. So intrasaccular flow disruptors are devices which are designed to sit within the sac of or neck of an aneurysm, and then they cause intra-aneurysmal thrombosis. So these are mainly nowadays picking up, and they are becoming famous because they don't require any antiplatelet therapy. So ideally, if you have any foreign body in a parent vessel, then you have to give antiplatelet therapy. So these devices are within the aneurysm or at the neck of an aneurysm. So they don't require any antiplatelet therapy. So that's why these devices are becoming popular nowadays. And currently, there are many intrasaccular flow devices like 𝑨𝑪𝑵𝑺, Artise, Luna, Contour, Medina, Lucid, and Seal, out of which 𝑨𝑪𝑵 is the most common and very famous one. So 𝑨𝑪𝑵 is woven endo bridge. So it consists of braided mesh of neonatal braided layer. It was first used in 2011. Initially, it was a dual layer mesh, and later it was called 𝑤EB-DL. DL means dual layer. Later, it was changed to single layer, and now it comes in two varieties like 𝑤EB-SL, which is a 𝑤EB single layer, which SL is a regular one, which is almost a rectangular in shape, and 𝑤EB-SLS, which is a 𝑤EB single layer spherical, which is almost circular in shape. And the other varieties are 𝑤EB enhanced visualization EV, and 𝑤EB can be delivered through smaller microcatheters, which are the recent ones, which are 𝑤EB 15 and 17. So now currently the web indications is mostly at present the web is being used in the wide neck bifurcation aneurysms, mostly at the internal carotid terminus, basilar artery bifurcation or anti-ACOM aneurysm bifurcation and MCA bifurcations. But there are recent studies which are showing that web can be used in the regular aneurysms as well. So currently the web comes in sizes of 3 to 10 mm in diameter. So aneurysms which are in between 2 mm and 10 mm can be safely put with the web. So these are some of the examples taken from the literature showing the web placement in aneurysms. So first one is the ICA terminus aneurysm, which was successfully treated with the web device. Similarly, this is a ACOM artery aneurysm, which was treated with the web. And this is the MCA bifurcation, which was treated with the web. And it shows complete occlusion of the aneurysm. So coming to the main problem with the web, the size selection of the web device. So web implantation is very easy, but the selection of the web size is very important. So because if you don't select the adequate size of the web, so it will lead to unnecessary wastage of the time and resources. So always remember, so if you compress the web by 1 mm, it will elongate its height by 1 millimeters. So based on this, we always choose the size by oversizing the diameter by 1 millimeter and reducing the height by 1 millimeter. So first, what we should do is this right side diagram represents the one is regular aneurysm and one is irregular aneurysm. So always take 2 dimensions. One is the height and one is the width of the aneurysm in 2 projections. So first is the AP view and second one is the lateral view. And after this is an example picture showing. So after you get the 2 dimensions, so get these 2 values. So first get the minimum aneurysmal height. So this is the minimum aneurysmal height, for example. And then you have to get average aneurysm width. So the average of these 2 should be taken. And so once you calculate these 2 measurements, then there are sizing charts. According to the sizing chart, you can choose the optimal web device. And this point has to be kept in mind while placement of the web, that the web stays in the aneurysm by lateral compression. So always it should have lateral compression on the wall of the aneurysm. So if you put the web and it is showing like this is an ideal placement of the web. So after placing the web, it should not be like this, like exactly how we see in the pictures. So it should be little bit compressed at the lateral wall. So this chart shows the sizing of the web. So there are 2 different sizing charts for web spherical and web normal single layer. So once you get the aneurysm height and once you get the average aneurysm width, so you have to place 2 lines here and 1 line here. So wherever the 2 points are intersecting, so that will be the size of the web. And you can select the microcatheter also based on the sizing chart itself. So there are different color codings. So according to the, for example, if our web size is 7x5, so the sizing catheter will be via 17. So that's how we select the size of the web. And there have been many studies which have evaluated the web, and there are many high quality studies, and there are mainly 3 studies. 2 of them have been done in Europe. One is webcast study and French observatory, and in USA it is of WebIT study. And there are some additionally current studies which are going on also. One is Claris and one is Clever and WebIT China. So we have 2 long-term studies. One is WebIT and Webcast 1 and 2, which have 5 years follow-up in angiogram. So these 2 studies have shown good occlusion rates. So one is 87% and one is 77%. So based on these 2 long-term studies, so they have concluded that the web is a good device for long-term occlusion rates. So now we come to advantages and disadvantage of the web. So first thing is web is very safe and effective, and it is also easy to deploy. So we have to enter it with a single entry, and in the experienced hands, we can deploy it with a single entry also. And the advantage is there is no requirement of long-term antiplatelets. And the one more advantage is it can shorten the duration of the patient's anesthesia and reduce the radiation and contrast exposure, in contrast to the regular stent-assisted coilings. One disadvantage is it has to be patient operator has to be a little experienced for the web deployment, because not all centers are currently practicing web, and occlusion rates are still doesn't match the stenting results. So now we move on to web in the ruptured aneurysms. So there has been a progressive, constant increase in the interest in the use of web in acute ruptured aneurysms. So there was one single center study which has revolutionized this concept. This is the paper published by the center, and in that study they have studied on 100 ruptured patients. They have put web in 100 ruptured patients, and on 3-month angiographic follow-up, they almost 73% were completely occluded, and 23% had only small neck remnant. And there was no rebleeding rates after the web placements. So after this study, it has led to the starting of a CLARIS trial. CLARIS trial is a multi-center study conducted in 13 European centers. This study is now being studied to determine the ability of the web to prevent early rebleeding, which is the main problem in the ruptured aneurysms. And currently, the early results are very promising. We have a 0% rebleeding rate after 1 month and 1 year. And there was no web-related problems even in 1 month and 1 year. And in 1 year, overall mortality was 3.8%, and overall morbidity in 1 year was 9.6%. The morbidity is due to vasospasm and the other problems. So after the CLARIS study, they have concluded that the web results are very good in the ruptured aneurysms. So people have now started using web even in the ruptured cases also. So next we move on to the newer device. So this is a contour neurovascular system, which is also called CNS. So this is a self-expanding, has both flow diverter and flow disruptor qualities. So once it is opened, it forms a funnel shape, and also like a chalice shape, and which the chalice sits in the neck of the aneurysm. And the advantage of it is it can be used even in the difficult and complex shapes also, unlike the web, which has only some fixed shapes. So this is a promising device which is coming up. So there are some advantages of CNS over web. So the advantages are it is easier to size. In the web, the main problem was to size the web. And in the CNS is more predictable, and the deployment is also more gradual. Unlike the web, which has a slightly popping out when you deploy the web, it has a slightly popping up nature. So that is not seen in the CNS. And because it reconstructs mainly the neck of an aneurysm, so it also has a highly effective flow diversion in the neck of the aneurysm. And in the serious trial is currently evaluating the effectiveness of the contour systems. 34 patients were enrolled in the CNS trial, and then complete occlusion was seen in the 44% at 6 months and 69% at 12 months. So according to Richmond-Ray grade 1 and according to Richmond-Ray classification, adequate occlusion was seen in 84%. That is grade 1 and grade 2. So this is an example of how CNS system is being deployed. Picture B shows the deployment of CNS here before placing it into the neck of the aneurysm. And this is a device picture which shows the sitting of the device at the neck, and you can flow divert and support it. And there are some differences between web and contour systems. So mainly, as I have explained, the contour is easy to deploy and easy to size, and the short learning curve is better in the contour, as said by the current many intervention surgeons. And there is a new device also, NextEnd device. So NextEnd device is an adjective flow diverting device, which also targets the neck of the aneurysm. So this is the NextEnd device. So it after placing the device, it tightly adheres to the secures the aneurysm. And after the placing the device, you can pass a microcatheter and you can tensely pack the aneurysm. So once the packing is done, you can remove the device also. So there is no requirement of long-term antiplatelets also, and it also can be used in the acute aneurysm. So this is a device which is being promised in the treatment of acute aneurysms, and it is currently undergoing clinical trials. Next, we have a Medina embolic device. So MED is from the Medtronic, and it is like a 3D complex intrasaccular device. So this is a 3-dimensional shape which is placed into the long axis of the wire. So once you deploy it, the leaflets come out of the axis and they form a spherical shape as shown in the picture B. So once the Medina framing device is placed, then you can insert some coils for the stabilization of aneurysm. So this is a picture taken from the paper published. So here they have placed in the Medina device in the right middle MCA bifurcation aneurysm. So here they have placed MED framer initially, and then after that they have placed 3 coils inside the MED framer to completely occlude the aneurysm. So after 3 months follow-up, the complete occlusion was seen. So this down picture also shows the similar framing of the MED device in the MCA bifurcation aneurysm, and then placement of only single coil, which showed the complete occlusion of the aneurysm after 1 month follow-up. There is a new device also, Lucid Dome, which is now currently undergoing trials. So the advantage of this device is it can be used both in sidewall aneurysms and even in bifurcation aneurysms. So the one more advantage is you can implant it from many angles. So the advantage is you can even if the angle is difficult, you can go and put this device, and you can secure the aneurysm by coiling. Once you go and deploy this device, it will be easy to coil, and it can be used even in the acute rupture cases also. And because it acts as a flow diverter also, because of high density coils at the base of the device, at the neck of the aneurysm. So in conclusion, intrasaccular devices. Sorry. So in conclusion, intrasaccular devices are easier to use and can eliminate complicated long-term stent-assisted coiling, which takes a long time, and it can eliminate long-term use of antiplatelets also. And they almost, even though the occlusion rates doesn't match the stent-assisted coiling, there is good occlusion rates, and in future it may replace a significant number of stent-assisted coilings. So web is very safe and offers a good adequate occlusion rates. And contour is better, more effective than web. And NextEnd can be used in the treatment of acute rupture of aneurysms in coming days. So in future, we can see more of the intrasaccular devices than surgery and stent-assisted coiling. Yes, thank you.
Thank you, Harry. And may I invite comments from our discussion, maybe Professor Oliseng? Any comments on those intrasaccular device?
Thank you, Ben, for invitation. Thank you, Dr. Harry. Actually, very good observe presentation. Actually, I have no to add anything to your presentation. Actually, you highlighted all the main methods which are appeared on the market for the recent days. Maybe I can ask a question, but how do you see the further progress in this direction? What maybe you analyzed all the recent trends in endovascular. So maybe you can say about something. What will be proposed in future?
Since now actually the web is now currently very famous out of all.
Yes.
So even though now currently many centers they are using only for wide neck aneurysms, now I have studied in one paper they have used it for almost all aneurysms. So it can potentially be used in any aneurysm in coming future days. So the only thing is we have to get some more shape. It is very easy and fastly deployable. So the learning curve is also not very difficult like stent-assisted coiling or balloon-assisted coiling. It can be learned by even neurosurgeons also very fastly. So I see in future the intrasaccular devices are going to take up the aneurysmal endovascular treatment. And the coiling and stent-assisted coiling mostly will be left behind. And these are the future.
Okay. So thank you, and congratulations for a very good review. Thank you very much.
Professor Tristan, any comment from you?
Okay. Thank you, Professor Harry Karen. Nice presentation and good achievement. Thank you very much. Thank you.
Maybe Professor Ju, any experience of this device in your center or China?
Yes, actually, this is very interesting. We always focus on the trend of treatment especially for the endovascular treatment for the aneurysm. But the trend we noticed that we observe that we have different stage to treat the intracerebral aneurysm. Before, we always focus on the dense packing of the aneurysm, use the coils. But now we more focus about the reconstruct of the parental artery. I mean, now is the less and less coils we used. More and more we notice about how to treat the aneurysm neck than the aneurysm itself. Maybe in future we will invent more instruments to treat the aneurysm. But now still in controversy about the web and the contour and also Medina, because still have some. I think still we didn't approve it's much better than the coil, traditional coil and stent. This is my opinion.
Okay. Thank you. And I can see a raised hand from Dr. Berhane.
Yeah, thank you very much. Nice lecture, and very nicely all the kinds of endovascular devices. I'm neurosurgeon in the Netherlands, originally come from Afghanistan, and that single center with the web design in a trial that was in our center in the Netherlands, and our group of neurosurgeon and with endovascular neurologists, they form a good team. It is very good precision. I agree with that. But if I look to the mitral cerebral artery aneurysm, it seems still good to clip that one. It is a big discussion in every other scientific meetings, because the remnants of the neck, it is in one issue. And in that case, you have to make still more and more control angiography, which also has some risks, of course. And for ACOM aneurysma, I agree. So a web or maybe contour, it is a good device to treat the patients. But the best way to do such treatments is to just to agree with your inside your team after discussion, and in selected cases, which is better to do endovascular and which with surgical clipping. So it needs always good discussion. So that was my point. Thank you very much again.
Okay, thank you so much. If there's any comment from the floor, Takashi?
Okay, thank you, Dr. Kiran, for the wonderful lecture. The web is new to me. So in this institute in Japan, several institutes are used, and compared with stent and coil, so that would be a better. Would be better, but the case is very small. The number of patients is very small, so I will expect for future results and future development. Thank you.
Thank you.
Okay. Thank you so much. And maybe we move to our last lecture. The last lecture will be provided by Dr. Sharon, who is the consultant neurosurgeon, KBJ Joe Ho Specialist Hospital, senior lecturer of the Monash Medical University in Malaysia. She is also the chair of the WIN chapter of the ACNS. Today, her talk will be MVD for trigeminal neuralgia. Sharon, please.
Okay. All right, so can you all see my screen now?
Yes.
You can hear me? Yeah, sorry about that just now.
Yes, it's
Yeah.
okay.
Thank you very much, Prof. Kato, the YNS team, and also to Dr. Liu for inviting me today to speak. I was actually cracking my head what to speak. Anyway, if you're going away from endovascular and vascular, and I'm going to talk a bit about microvascular decompression for trigeminal neuralgia, mainly aiming for the YNS who are present here today. Like Prof. Zhu, I have known Prof. Kato, I think almost 20 years. I met her when I was just starting off as a resident. And today I have actually the honor of being the chair of WINS for the last couple of years. So I'll just start my presentation. So what is trigeminal neuralgia? It's basically pain over the trigeminal nerve. So it's a stereotypical pain. It's described as sudden, unilateral, severe, paroxysmal, brief, stabbing, lancetating, different kind of way the patient will come to you. It's usually triggered by non-noxious stimulation with pain-free interval. So the fifth nerve is actually the largest cranial nerve. It combines both of sensory and motor fibers. Its supply can be divided in three branches, the V1, V2, and V3. And the most commonly affected in trigeminal neuralgia is usually the V2 and V3 branches. So the incidence is about 4 in 100,000. Age is about 5th to 7th decade, mostly in female compared to male. But in my experience, most surgeries I have done has actually been for male patients. I'm not sure why, but surprisingly, more male patients have presented to me. Most commonly, the cranial nerve is a cranial nerve vascular compression syndrome. So what happens actually? So the nerve is comprised by a vascular vessel, and because of the chronic compression, it causes demyelination of the large diameter A fibers, and that causes ectopic impulses. And then it demyelinates zones would behave like neosynapse, and this causes pain. So commonly involved is actually the superior cerebral artery. And how do we diagnose it? So diagnosis is actually basically a clinical examination. So when it comes to trigeminal neuralgia, it's usually a multidisciplinary team effort. Usually the neurologist is the one who sees the patients, they treat the patients, and in failure of treatment, they will refer to a neurosurgeon. But sometimes we do get patients that come directly to us. These are patients who are usually well informed. And most of the time I notice that when you see patients for trigeminal neuralgia is usually in the professional class of patients, because these patients taking medication such as carbamazepine sometimes have side effects. And because of that, it affects their work performance, and then hence they come to see you because they have read through and they decide that this is the best option they would like. It's a microvascular decompression. And normally it's the absence of sensory deficit is an essential for the diagnosis. It usually responses to anticonvulsant, primarily carbamazepine. And when you do an examination of the patient, usually the trigeminal nerve should be normal. And it involves few investigations, but the most important is the MRI. So usually when you see a patient with trigeminal neuralgia, the first thing you need to do is speak to your radiologist, your neuroradiologist, and discuss and get a high resolution MRI. There are three sequences that are very important. The 3D T2 high resolution, which is the Fiesta and the CISS. It's either or, and of course the time of flight MRA, and T1 gadolinium. T1 gadolinium is usually because you want to rule out if there's a small lesion, or most probably compressing on the fifth nerve, and might not be a trigeminal neuralgia. It could be caused by a lesion. So sensitivity is higher with the 3 Tesla, but you can always use a 1.5 Tesla MRI. So here you can see a high resolution MRI where you can look at the fine images of the nerve roots. And the signal of the CSF is usually high signal, and its surrounded structures have low signal. So here you can see the trigeminal nerve, and you can see the SCA is actually curving on top of the trigeminal, looping over the trigeminal nerve. Here again on the sagittal view, you can see very clearly the fifth nerve with the SCA looping over it. If you do your MRI and you see a lesion, then you most probably neuralgia, but most probably a schwannoma. And the TOF MRA, the reason we perform them is actually to visualize whether it's an artery or a vein, because sometimes the vein can also compress on the nerve and also cause neuralgia. So vein accounts about 39% of cases and separately about 25%, but in association, most of the time you will find artery with vein, right? And the most common vein is the superior petrosal venous system, and on and off is the transverse inferior vein. The MRI is also important because it helps us to grade, and the grading actually sort of prognosticate when we do the MVD, whether how successful it will be. So it's graded into grade 1, which is a simple contact. Grade 2 is distortion of the root, and grade 3 is marked indentation in the root. So where is the site of compression? The most common site is at the root entry zone, which is about 50%, and then in the mid-cisternal portion, about 40%, and only about 10% is near the Meckel's cave. All right, it's the commonest conflicting vessel at this site, and is the pontine transverse vein. Open up when you do an MVD and you cannot find the vessels, you need to make sure you explore completely, all right, so that you do not miss any and 79% respectively. Grade 1 has about 65% cure rate. Treatments, first of all, they usually start with medical treatments. Carbamazepine, second line can be gabapentin or baclofen, and third line pregabalin or phenytoin. Normally, if the patient is already on multiple medications, then this patient usually is a candidate for MVD. Surgical intervention is physiologic, is MVD, and also ablative or lesioning such as percutaneous rhizotomy, which can be divided into radiofrequency ablation, balloon compression, or glycerol injection. And of recent, stereotactic radio surgery has also taken a front line in treating MVD. Just to say that I had one patient that came to me, and this patient actually had a trigeminal neuralgia, and he was a doctor. He didn't want any medication because his main reasoning was because medication would make him would cloud his judgment and make him a bit drowsy and sedated. So he actually didn't even try medication. He immediately came to me and wanted a MVD done. So let's talk a bit about microvascular decompression. It was initially first demonstrated by Janetta, the efficacy of micro in 1967. And interestingly, Janetta at the time was actually a resident when he actually demonstrated this MVD. So to all the YNS out there, you know, this is actually an inspiration to all of you. So it's never too young for you to come up with any kind of innovation. So treatment of choice was for trigeminal neuralgia, but we can do MVD in other cases. The reason why I talked about trigeminal neuralgia is because it is actually the most safest to do, because the trigeminal nerve is actually quite resilient. If you have hemispatial spasms, most probably it's the seventh nerve. Or if you have, I have one patient with a disabling postural vertigo. He came in with intermittent vertigos, and I had to do an MVD for him. And of course, after that, he improved, but his hearing was already involved. So there was less pressure on me when I was doing the surgery. So this surgery is a non-destructive treatment, is curative. However, it is invasive and is associated with surgical morbidity. And this is what is sometimes a bit deterring to patients when they decide for treatment. So indications is usually failed management, inadequate pain control, and dose-limiting side effects after 1 year on medical therapy. So usually after a year, if the pain is not well treated, patient has side effects, then of course MVD is an option. Patient is healthy with no comorbids, and age is usually younger than 70 to 75. So the older the patient is, of course, the other options are, you can always try radiofrequency ablation, rhizotomy, or also SRS. So here, just a little bit on the most commonest types of vessels that you see in trigeminal neuralgia. The vessel looping is most commonest is the superior cerebral artery, about 57%, and then of course it's the ICA second. So what do you do when you plan for an MVD? So to make the surgery at ease, of course we need the microscope, definitely. And other adjuncts that can help is the intra-op neuromonitoring. This I would recommend, because sometimes when you open up and you're still new, this can assist you to identify the nerves. And of course, the IGS, image guided system or neuro navigation, it helps for you to localize and open up accordingly. Position can be supine or park bench, depending on what you are familiar with. Incision, it depends also on what you're familiar with when you do your retrosigmoid approaches, whether it's a linear, a C shape, or a lazy S. And then, of course, your muscle dissection, followed by the burr hole. And this is very important because the burr hole, where you put the burr hole and the exposure, will assist you to facilitate the surgery. Because normally the MVD is a keyhole surgery. You try to keep it to the minimal, the craniotomy size about 3 × 3 cm. And of course, the dura, again, preference to which type you prefer, L shape, T shape, or C shape. So here is the drawing. So before you start your incision, of course, you want to delineate where is your transverse sinus and your sphenoid sinus. And then you can either do a linear, a C shape, or a lazy S. Okay, and where is your borehole choice is usually at the asterion. Okay, like we've all basically learned. So what is the asterion? It's actually the meeting point of 3 sutures, your lambdoid, your parieto-mastoid, and your occipital-mastoid. And also 3 bones, your parietal, occipital, and your mastoid portion of the temporal bone. So basically, this is the junction of your transverse and sphenoid sinus. So what materials do we use to insulate or interpose between the nerve and vessel? Normally, we use the Teflon or Gore-Tex. All right, it's a puff or felt kind of graph. Okay, Evolon, carotid patch, muscle, gel form Surgicel, I wouldn't really encourage because these do reabsorb, and sometimes it does cause adhesion, so the patient might come back with symptoms, all right, or fascia lata or dura. So what happens is these are the different types of vessels that you can find interposing or looping around the vessel. It can be behind or in front, depending. Okay, so the important thing is for you to identify and then you interpose the insulating materials. So this is actually the original diagram from Janetta's procedure, where you're interposing the insulating materials to lift away the vessel loop from the nerve. So here's a few pictures of surgical pictures. So here you can see when you open up, you can see there is a vein actually sitting on top of the trigeminal nerve. And then what you do is you loop up or you free the vein and artery, and then you slip the insulating material in between the nerve and the vessel. So this procedure basically needs a lot of dissection. You're actually dissecting in a normal anatomy. So most of us who are vascular surgeons are usually quite comfortable with this kind of a surgery because you really deal with a normal anatomy. But again, it's very important to have steady hands, be patient, and take your time when you're doing the surgery. So here you can see there's just an opening about 3 times 3 cm. This surgery actually was done by my assistant specialist or my junior specialist, where I supervised. All right, and here you can see this is your exposing up here is the 5th nerve, and the 7 nerve complex, 7 and 8 nerve complex, and below here you can see is your 5th nerve. And you can see this is actually the ICA, which was looping and touching onto the trigeminal nerve. Here is putting in the insulating material in between the 5th nerve. So when you're doing this procedure, you have to be careful. Do not at all, touch the 7th nerve. The 7th nerve is quite sensitive. A bit of manipulation and you can have a 7th nerve palsy. And again, here you can see putting in an insulating material in between the looping vessels. So now there is a new technique that has been introduced. It's called a sling retraction technique, which was introduced by Steinberg et al. This technique actually recommends, because there are theories that come up that sometimes the insulating material can slip. So there have been incidents where they see slipped, but usually if it's done well, it shouldn't. And so far, I've not had any patients that come back with this problem. But this is a new technique. And it's a technique that you can use if you are interested. So what are the complications that we normally see in a microvascular decompression? This is very important. So the most common symptoms are actually your facial palsy. All right, so any nerve deficit can come upon. But of course, when you look at this graph, you will see that the least is actually on the trigeminal neuralgia. You have more common in your hemifacial spasms and in your glossopharyngeal nerve. They tend to develop more complications because, as we all know, the 7th nerve and the lower cranial nerves are more sensitive. Okay, and the complications you can develop because, as you know, you're opening up the posterior fossa. Sometimes patient can have severe vomiting, headache post-operatively because of excessive CSF drainage. Sometimes facial dysesthesia, ataxia. They can have hearing loss, deep venous thrombosis, but these are all very minimal. And most commonly, to be careful, is your CSF leak. So it's very important to make sure that the closure of the dura is done well, watertight, and if possible, you need to secure it again with thistle, then please do. So these are some of the studies that were done. This is by Haridas on refractory trigeminal neuralgia and long-term results in 405 refractory trigeminal surgeries in 256 patients. And here you can see 85% of the patients who underwent MVD in this study, they were pain-free for 3 years. So surgical intervention shows to be quite successful. And here again, long-term effectiveness. And this was an 8-year study where they showed about 80% of the patients were free of pain. A little bit on SRS because now it's something new, but maybe I can get some input from the panels here today if they have any experience with SRS. So the principle is actually radiation-induced damage to the root entry zone area. And going through a lot of papers, I noticed one thing is you have to have a good MRI because you need to localize very accurately the REZ area. So the indication for SRS is usually failed medical therapy, are the few types of treatment that you can find for microvascular decompression. There's the thermorhizotomy, there's glycerol neurolysis, balloon compression, stereotactic radiosurgery, and microvascular decompression. So out of this, the long-term outcome that is the best is still microvascular decompression, about 62 to 89%. So prognosis overall is a favorable outcome, excellent outcome in 10 years, and a probability of cure is about 75%. So how do you make a decision when the patient comes to you? First of all, if it's not a trigeminal neuralgia and do not have an MRI that supports it, then you can either try lesioning or stereotactic radiosurgery. If MRI supports it, then of course, a patient has a good condition, you can proceed with MVD. In failure, then of course, again, back to SRS or ablation. Thank you.
Thank you, Sharon, for sharing. Shall I invite Professor Lee Seng to comment first?
Dear Sharon, thank you very much. Great presentation, a very good very good summarization of the existing data. So actually, I tried to find some weak points in this, but didn't succeed. It's really great. Thank you very much. But let me highlight maybe some points of your presentation. First of all, you told about it, and I want to emphasize it. It's a very important, the patient selection for microvascular. The better selection, the better results. It's a first choice. And you describe the classical neuralgia, which could be treated and in which we really expect a good outcome after our surgery. Another point in diagnosis, so the proximity of artery and fifth nerve root doesn't mean the conflict among them. Actually, anatomically, they are always very close to each other. For me, I can speak about conflict only in cases when I see the strangulation stripe on the nerve. Only in this case, I can say, yeah, really, this is conflict. They are altogether, I'm searching for something else. I dissect, I don't see the stripe, and I go on searching to find another reason of this pain. And believe me, sometimes I found, and thank you very much that you emphasized the venous conflict. It's important, really important, and sometimes it's underestimated during surgery. Sometimes I find the venous conflict on the opposite side. Moreover, I ask my anesthesiologist to perform a kind of Valsalva probe to increase the venous pressure, because extended vein will show you the place of another compression. Sometimes it could be even dual compression between artery and vein. It's also possible. And so again, thank you for that you paid so much attention to the venous. Venous is very important. And another one is arachnoid bands in this region. Also, the third one, artery, vein, and arachnoid bands, which may compress the vein, which may displace the artery. Once you cut it, you will resolve the problem at all. Then in my surgery, I have not the hundreds of cases of conflicts. I have not a big flow of patients, but I operate them from time to time and analyze each of these cases. I don't believe in the Teflon patch or muscle patch in between conflicted structures. I believe in creating a new anatomical relations. So what I do, I always perform the wide dissection of all this area. I release everything is free. After that, I fix the artery and vein aside of the root to be sure they do not touch at all. Because putting Teflon in between them it means that you will have improvement for 3-5 years maximum, and then you will have recurrent trigeminal neuralgia. So it's my idea, it's my experience. So that's all, and thank you, and my congratulations for really great presentation. And one more remark. I'd advise you to use more sharp dissection. Don't be afraid. Work sharply. It's believe me, it's more safe. It's much better. So thank you very much.
All right, thank you, Prof. Alexander. I think the thing here we should say, I mean, to the YNS is, I think here if you're obsessive and compulsive, it's very good. That's what I would say, you know, being obsessive and going and looking around and making sure, like what you said, all the arachnoid layers have been opened up and you can see everything fully. And I think next to chronic subdurals, I think microvascular decompression is one of the most
yes, you will.
In neurosurgery, actually, because that's the immediate, you can see immediate result. It's like after surgery, the patient goes back, you see him and he'll say, she will say, thank you very much. You know, you've done a great job. So I think it after chronic subdural is the most gratifying surgery in neurosurgery. I mean, you know, most of our surgeries, sometimes we spend sleepless nights after the surgery thinking, is our patient going to wake up? Is he going to have a neurological deficit? You know, even if you do sleeping, that thing goes on, you know, like, is the second day something going to happen? But I think this is one of those surgeries that if you do it properly, it is gratifying, and you know, you see the patient for years to come, and it's something good, I believe.
Yeah. Yes.
Yeah, you have some Prof. Ask me.
Sorry,
Prof. Zhu, I think he has a comment.
Yes. Yeah, not comment.
Okay.
Actually, this is a very interesting topic. Can you hear me? Yeah. Okay. Yeah. And because when I followed Professor Yoko Kato and also Professor Kano, they always pursue 100% of for the success for the treatment for the MVD, and I noticed they always use endoscopic during the operation to check every single detail of the microvessel decompression. So I think it's very useful. I'd like to introduce you to use the endoscopic during the microsurgical operation. This will help you to achieve more successful operation. Another one is, I just want to hear how much percent that you encounter the hearing loss after surgery, because we do encounter some this kind of complication after operation. We don't have the facial force, but we do face some hearing loss after surgery.
Okay, so for hearing loss, no, I've never come across, actually, surprisingly, but facial palsy, there was one. Because actually I supervised one of my junior specialists, and I think he was a bit too, maybe just a bit of this. So I say you have to be careful not to, you know, disturb the nerves around but it was just a temporary, and the patient recovered. Well, it was about, you know, facial palsy about a month or so, and then it was, then he recovered. But hearing loss, I've not had, unless it's, of course, like I told you, 8th nerve compression. Yes, that I have met, but not from the 5th nerve. And yes, I forgot to mention about the adjuncts endoscope. A 30-degree endoscope is actually helpful. Unfortunately, in my center, we don't have it, so I couldn't show you. But yes, that is actually very helpful. Totally agree.
Yeah, and how about if you failed to, I mean, if the patient still recurrent, the neuralgia after the surgery, what's your choice to give the patient? I mean, the balloon. You also mentioned the gamma knife. Yes, and also, but usually we will give the patient balloon compression, especially for the secondary attacked patient, because this is a very headache, because patient already experienced the open surgery. Now the neuralgia come back again. So also, did you ever perform the trigeminal amputation for, I mean, the cut part of the trigeminal nerve? You never. Okay.
I only do radio frequency ablation.
Okay, thank you.
Professor Pritchard, any comment from you?
Thank you, Dr. Sharon. very excellent presentation and achievement. Thank you very much. And just I like to know your advice for continuation of medical treatment after MVD. Thank you.
So usually after MVD, the patient is I off all medications. So they don't need any more medications actually. So that's the main reason, yeah. So there's one patient that always stay in my mind is this doctor. He really didn't want medication. He came to me, he did the surgery and he went home. He said, thank you, doctor. He just was so against taking medication. So yeah, they don't need medication. You can stop the medication immediately post-operatively.
Okay, thank you. Because previously they advised for continuation of carbamazepine and gradually tapering. Okay, thank you.
Off like how we do all epileptic drugs, but yeah, they don't need actually after that.
Okay, thank you.
Maybe Sajjan. Is Sajjan here? Any comment from you, Sajjan? Maybe Professor Takashi, any comment from you?
Okay, thank you for the great presentation. As for transposition, our institute also use transposition. If the offending artery is SCA and thick basilar artery itself, so the sling technique we use. So in that sling technique, sometimes the success rate is a little lower since the basilar artery is very thick, very long-term compression. So in your institute, in your experience, so the not successful case, or sometimes not recovered case. So if the offending artery is thick or offending artery, basilar arteries are serpentine-like and the long-term compression. So in that case, do you have any experience? Have you experienced any such cases?
So yeah, I mean, had maybe one or two cases like that. So usually, like what was suggested, sometimes we do offer patients SRS. All right.
Okay.
Yeah. Sometimes we give them that option because then sometimes the pain comes back, but it's not as bad as it was in the beginning. So it's usually slightly less. But I noticed this most common, not in trigeminal neuralgia, but in hemifacial spasm. That's what I see more common.
Okay, thank you.
Okay, may I ask, are there any comments from the floor?
I think if the Professor Yukato, he just mentioned that we can use a sling technique. I mean, if you encounter the serpentine shaped the compression, so you can use a sling technique. Of course, actually, I also want to mention sometimes trigeminal nerve amputation also is one of the options. I mean, for the recurrent neuralgia patient. At least they can stop the pain. I don't know if anybody against it. Just my personal opinion.
Maybe any comment? Yeah, post in it, Professor.
Yeah, I have this comment. So I want to just repeat the phrase I've heard from one of my teachers, and he told that if once your patient will have anesthesia dolorosa after your surgery, you will never perform again. You will never again perform the posterior rhizotomy of the fifth nerve. That's a phrase of one of my teachers. So I never do it because I'm afraid of because you know, the anesthesia dolorosa is a terrible complication of this manipulation, which may happen in some of the patients after this. It's my option.
Yes.
Maybe Sachin, any comment from you?
Am I audible, Liu? Ben?
Yes. Yes, please.
Okay, so I had the opportunity to spend some time with Professor Fuminari Kamatsu when I was in Fujita, and he used to perform quite a lot endoscopic microvascular decompression. And there was one small study I did for the patient who has pain in the trigeminal nerve distribution, but radiologically there is no neurovascular conflict. And when we did the surgery, endoscopic exposure, obviously there was no neurovascular conflict. So what we had done is just something he called is nerve combing. Nerve combing is just with the ball probe with lead dissector. Since we are using an endoscope which is very high definition, with that endoscope you can actually see the nerve rootlets, and they are in the fashion that cranial nerve.
So yes. Okay, so Dr. Sachin, the so-called neurolysis. So we do. So we do the more than 200 cases per year at our institute. Please continue, Sachin.
Yes.
Please continue.
Yeah, I'm sorry, my network is really bad because it's raining here. So we had done, I could observe maybe around 10 cases where there was no neurovascular conflict, but he would do just a nerve combing, or he will call nerve massage, wherein he will massage the nerve rootlet, especially in that particular rootlets where the patient is having pain. Like the patient is having pain in the V2 and V3, which is the most common one. He will do the massage only in the lower rootlets because they are in that particular fashion. Sometimes he will do the massage with the ball probe, or sometimes if the rootlets are very loose, he will even put a small plate dissector and he'll gently, maybe he'll try to release it. I don't know what is the pathogenesis, but maybe you are damaging the nerve to the extent that the pain will stop to occur, but the nerve still continues to function. And none of the patient had persistent dysesthesia or any anesthesia in that particular area. Maybe for few days it may be there, but after that it was never there. And every time he does transposition and not interposition. With the special glue technique, he will just take the nerve and or towards the tent, and to that tent he will glue it to the tent. So it was very, very promising, and when you do it personally, it's very difficult to do.
Maybe I can continue. So the last year we did 200 cases. So on the pure endoscopic procedure, so no more microscope. So of course endoscope is very high illumination and high resolution, very high magnification. So we can see very clearly everything. So the transposition is the first priority, and also the concept, if the tap the offending vessels, then we for that case maybe we can add the transposition plus and the insertion. Maybe some relief of the compression is even though I think it may some effect for the this neuralgia, I think. So maybe I think you can introduce the endoscope, and the surgical procedure is less than 2 hours. Very less invasive for the patients. Very effective, the result. I think maybe Dr. Hari, he knows everything, I think. I sensei? Yes?
Yes, Professor. Hello. I was in Japan under Professor Kato Sensei. So I have seen the transposition technique. Dr. Komatsu Sensei used to perform this. It's very effective. Previously at our center, we were not doing the neurolysis part. We always used to decompress the trigeminal nerve, and then our surgery is over. That much we used to do. So after seeing in Fujita University, then we started doing some neurolysis, and I have seen some good results at our center also. And it does benefit. I don't know even the mechanism, but it really helps practically.
Hari? Dr. Ben?
Yes, Thank you so much, everyone. So if there's no further comments, so maybe I come to the end of this ACNS YNS webinar today. So today we have a really educational and a great discussion and a very meaningful day for all of us. And I would like to thank you all of us for joining this webinar. And again, I'm so happy to see all of you in this particular festival, the Chinese Lunar New Year. And thank you so much for joining this webinar. So on behalf of the Educational Committee and Professor Kato, I would like to thank all of the invited speakers and also the audience for joining us today. So it's time to say goodbye, and I hope to see you next time. Thank you so much.
Thank you, Dr. Ben.
Thank you. Thank you. Bye.
Bye-bye.
See you.
Bye.
See you.
Professor Yoko Kato.
気をつけて。
Bye.
はい。
Thank you.
おやすみ。
ありがとうございます。
ありがとう。Thank you. Bye bye.
Thank you so
気を
much.
つけて。
Bye.
Professor Kato.
Bye.
はい
再见。再见。